So let's start off with the antibodies, because I think it's a really amazing story for us in myeloma, a disease that I've said for a long time makes too much of an antibody, hasn't had an antibody to treat it. So I call that oncologic irony. What I think is really interesting about it is that after decades of trying, we finally have a couple of candidates and we figured out how to really enhance their efforts. The first is Daratumumab, and Daratumumab is an antibody that targets CD38, which is on the surface of almost all plasma cells. It's also on some lymphocytes as well. And what's really quite striking about Daratumumab is that it has single-agent activity. And what I reported on at ASCO and at EHA was about a 30% single-agent response rate in refractory myeloma, median of 5 prior lines of therapy. Everybody was double refractory. A significant fraction were 3 and 4 drug refractory, which I think is pretty impressive. The second piece is the side effect profile. The only thing that was really unique to Daratumumab was infusion reactions. And while that occurred in about 40% of patients with their first dose, it didn't really occur often beyond that first dose. And so I think those are really encouraging and exciting elements. We know that combining Daratumumab with lenalidomide and with bortezomib even further enhances their activity. So that's a really promising and important target, and one that I think we'll have available certainly in the US within the next 12 months, I hope. The second was Elotuzumab, and Elotuzumab is an antibody that targets SLAMF7, which is not, it doesn't have single-agent activity, but when you combine it with lenalidomide, we showed a few years ago pretty significant synergistic interaction. And what I reported on at ASCO and at EHA this year was the phase 3 trial comparing Elotuzumab Lendex versus Lendex. And we showed about a 5-month improvement in progression-free survival. What I would argue is very significant promising data for an improvement in overall survival. But aside from those, if you look at 1 or 2 of the subsets, if you had high-risk myeloma, 17p deletion, it appeared we could overcome that with the addition of Elotuzumab to lenalidomide and dexamethasone. If you had 414, the same thing. And finally, if you look at response per response, so PR or better, the durability of the remission was much longer when you added Elotuzumab than if you didn't have Elotuzumab. The same for VGPR or better. So it's not just depth of response, but it's durability of response that really speaks to the power of immune-based treatments in myeloma. Well, I think we know that for older, frailer patients, the endpoints that we want to achieve are the same. Try and get them to complete remission, or even MRD negative complete remission if we can. That's harder to do in a frailer patient because of the toxicities of treatment. What antibodies really bring to us is a way to get at the tumor with very little collateral damage. And I think that's a really unique feature. The only thing you really see with the antibodies is infusion reactions, and that occurs in the first dose. Beyond that, it's pretty much gone. So I think the long-term side effects are really going to enable us to push the barriers of response for older, frailer patients. There's about 10 to 15% of patients at diagnosis who at 15-year follow-up are still in ongoing remission. So I would argue that those patients we're already curing now, and that's old data with old drugs from the Spanish group. My guess is that with the addition of some of these targets like antibodies, with understanding some of the mutations that we see in myeloma, RAS, RAF, MAP kinase, BRAF, IDH1, IDH2, that's going to help us to increase that cure fraction in the next 5 to 10 years. And my hopes are we can double it.